please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
I have to tell you something.
Yeah.
Because I did something this week that I didn't think was possible.
Oh.
Yeah, there's this. She's a Ph.D. research biochemist.
Okay.
Very smart. Had it's called Cavernous Hemangioma or a cavernoma. So it's a tangle of blood vessels. It was at the top part of her cerebellum and in between her cerebellum and her pons. And she had a stroke. And the problem with those vessels is they're fragile and they just break and bleed. So she got over the stroke and in about 6 months got all of her function back. And then some nice neurosurgeon said those cavernomas are still there and they can break again anytime. So I should go in and take them out. Okay, that was 1.5 years ago. And when you look, if you look in Netter, I think it's on page 117, those of you that have your books there, it's the base, it's the bottom of the brain that shows where all the nerves, cranial nerves come out and what they do. I have a frequency for the medulla, I have a frequency for the pons. But at some point in the last 10 years of his life, George got annoyed with me because I was less than enthusiastic about this whole page of frequencies he created for the mitochondria. And so he stopped telling me about frequencies that he scanned for. So I'm treating this lady. The first day I get only so far. And then during the surgery, so she's got long track symptoms that don't make, on the right side, it makes sense. She's got thalamic pain from the bleed that happened during the surgery. Because when you take out a whole bunch of blood vessels, this is the webinar everybody has from a long time ago that nobody watches. It's called Take It Apart. What happened in what order and whatever. So when he took out the hemangioma, the cavernous hemangioma, he had to cut off the blood supply. Oops. And so the right-sided body pain started 3 to 4 months after the surgery. Right leg, that's the thalamus. So I knew I got rid of that for sure I knew I could do that. But on the second day, I know George gave somebody frequencies for the cranial nerves. So I texted JJ, and JJ was awake and answering texts, and JJ said, here's the list. She couldn't move the right side of her face, couldn't close her eyelid. We haven't got to that nerve yet. We did. She couldn't do this. The facial nerve was affected, and that's motor. The trigeminal nerve was affected, that was sensory. I wrap around her neck, contact down the middle of her face, and I ran briefly, increased trauma, necrosis, torn or broken, but then just 81 and these cranial nerves. But 81 and there are 4 frequencies. I don't know how there are 4 frequencies for the facial nerve, but it actually makes sense because there's a branch that goes here, a branch that goes here, a branch that goes here, and here, eyebrow, right? And she couldn't chew. And when muscles are spastic, it's because they lose innervation, right? Before they get flaccid, they get spastic. Sometimes they just stay spastic. It's like having a sensory cortex stroke. You just get spastic. So her jaw muscles were spastic and then weak. So they wouldn't contract because they were already spastic.
Right.
So I'm running 81 and these 4 frequencies, and it's that those muscles just they didn't, they they softened, right? She went, I don't know. And then pretty soon after they relaxed, they started fasciculating, like they would just twitch. Oh, the nerves are talking to me now. I didn't think it was possible. There are 2 frequencies for the accessory nerve. She said, oh, I have this pain here in my shoulder. And so that's the upper trapezius. That's the accessory nerve. Here on JJ's list, George's list, there's the accessory nerve. So I unwrapped it. So it just was laid across the back of her neck and the base of her skull, and 2 frequencies for the accessory nerve. And she said, oh, it feels funny down below. Oh, I said, yeah, that's the lower part of the upper trapezius. It worked. Spasticity went away. And then she said, it hurts back here, base of the skull, and right here, sensory pain. This hurts. Okay, take it apart. This is not a cranial nerve. When they did the surgery, he went in between branches of the occipital nerve, which is the C2 nerve root. And so that was easy. C2, we know we can fix because that's just 396. So around 40 and 396 while I went and looked up something. And at the end of it's an hour, we spent 2 hours educating her and me about what these cranial nerves did and how it is. She had a disc bulge that was just touching barely the spinal cord. After this, that was an MRI before the surgery. After the surgery, her spinal cord is peanut shaped.
Yeah.
Because think of the position they have to put you in to get a fiber optic scope into the base of your skull. She had to be in hard cervical flexion on, right? So then there's this pressure in flexion on this disc. And so after the surgery, the disc pushes into the cord.
Mhm.
That created 40 and 10 and 81 and 10 down her left side and her right side. Right? So there's part of her symptoms. That's the take it apart part. Kevin just posted the take it apart webinar. That's the take it apart part. What about your long track symptoms is from your spinal cord, and what's from your brain? The first day I had 11 machines on her. Concussion in vagus, because you have to increase the circulation in the brain, right? And then what it was a thing. Thank you, George, and I'm sorry. And thank you, Jay. And
And are we going to see these frequencies somewhere?
at the advanced, and I will change the advanced laminate. Kevin just asked me 2 days ago, are your advanced slides finished? I went, oh yeah, sure. No,
Just kidding.
not just kidding. But that means I have to talk even faster at the advanced, and the advanced laminate is going to get longer. Actually, there's a whole sheet of investigational frequencies. An N of 1 doesn't mean that they're real, right? Sorry, everybody, it takes me at least 5 before I believe it. And that really used to annoy George. I'm sorry. And then by 10, you're pretty sure. Takes 20 before you're certain. But it gives us someplace to go. And it also means that FSM practitioners have to know more about neurology than most neurologists tell your patients. So this is a PhD in biochemistry. Native IQ, just talking to her, probably about 150. And we spent 2 hours talking about what these cranial nerves do, where they come from, why she's dizzy. That's because her 8th nerve goes to here and here, and this disagrees with that. And she went, why didn't the neurologist tell me this? either they don't know how to explain it, or they don't think you're going to understand it, or they simply don't have time. Could be any of the above.
Maybe all three.
Yeah. So that was 2 hours.
Right.
And mostly it was me educating me, to tell you the truth. Okay, remind myself, made my brain hurt.
Right.
And then, but then we have living visual. I didn't need a video. I had this person next to me with I can't even remember the name of the nerve, the one that makes her eye close. Her eye can't close.
Right.
Her eye muscles don't work right. So she just has a patch over her right eye. It's okay. So I had living proof of what each one of these cranial nerves did. And then we had the book in front of us telling us where they came from. Okay, that makes sense. Okay, now I understand why those nodes don't work, because the bleed and the hemangioma went to the pons. And the pons is where all these cranial nerves come out of. And so I educated her, and now I'm going to educate you guys. And I'm really sorry ahead of time, but it's going to be fun, really. And so maybe I'll find some videos about what facial nerve does, and maybe I can take pictures of this patient. I don't know. Anyway, so that was what I did the last 2 days. That was pretty fun.
So you led with, you did something that you were surprised that it works. When you say these things and then you explain the course of action that you took, I'm sitting here going, that makes sense. That makes sense. That makes sense. Like, you don't do anything that doesn't make sense. It's not like you're running frequency for the, I don't know, 10, like everything probably makes sense, I guess, if I tried to bring myself there. But it makes sense what you're saying. So I like that you took the leap of faith with the new frequencies as opposed to just running nerve.
They're either going to work or they're not.
Right.
And if they don't work, it's okay. George was wrong. And that's what I'm always waiting for, but he's hardly ever wrong. And it was, first you had to figure out how they're supposed to work and what they're supposed to do, and understand why her masseter like, so if you feel up and next to your, like from this bone down to that bone, there's a little muscle there, right? You've got an outie instead of she's got a hole. That muscle's just gone, right? Her jaw muscle, hard as rock, and she can't close her mouth. She has to chew soft things. Okay, what happens to a muscle when it's denervated? It spasms. Rock hard. So how do you undenervate it? You increase secretions in the nerve, and you just drive the mother. I'm sorry, I know you've been rode hard and put away wet, but come with me now. It's going to be fine. You have to do this now. Okay, but give me some ATP. Well, yeah, I got that. So the current does how do I do this? Because the nerve is asking you, okay, I'm willing. You're telling me what to do with this 81 and 292 thing.
Mm-hmm.
But how do I do that? I don't have 500% ATP. I guess I can try. And then the nerve goes, okay. So the first branch, all of a sudden this started to fill in, and I'm going, no. And the second branch was the fun one, because the masseter was just like a brick. Yeah. And it started to soften. So that's actually what we're going to end up doing in the neuro section. It's pretty fun.
That is fun. So I want to talk about this concept really quickly, because it's something that we talk about in the sports and the sports advanced, is when you have something that's called a tight weakness. A muscle that is chronically shortened, we say so you can have a tight weakness and a stretch weakness. So the tight weakness is like what you're talking about. When a muscle is spastic or chronically shortened, it's weak. It can't contract and relax. And it comes from two sort of philosophies of why that happened. You explained the first neurophysiological phenomenon about innervation, and the other is the mechanical property. So when the actin and myosin, so people who are just listening, you're going to have to, I'll verbally walk you through what my fingers are doing. My fingers are interlaced, and I'm having optimal space between them. So that would be like optimal actin and myosin. So the myosin and actin can pull, and that's our sliding filament mechanism, and the muscle shorten. But if a muscle is too tight and there's too much overlap, the actin and myosin can't optimally shorten. So you get this chronically shortened state, or a short weakness, or a tight weakness is what we call it. So I would even follow it up playing with the sarcomere.
Yeah, it takes the sarcomeres. You're doing this interlacing your fingers. I do this with the creepy crawlies because they have these little heads that grab each other and walk along each other.
Then hold on to the myosin, yes. And so they're like golf clubs that
Well, it
swing.
takes 3 ATP to make them go like this. It takes 2 ATP to relax them. That's where the ATP part comes. And
that's why go ahead.
Right.
No, I said that's why it makes sense when we use frequencies like 49 and 81 that this works, is because there's no more juice left, giving those myofibrils the energy that it needs to optimally contract and shorten. This just makes sense.
Yeah. And then in order to be strong, so strong and normal, a muscle has to be able to contract and relax. It has to be able to do both: contract, relax, contract, relax. You can't get strong if you're just doing contract. And if it's constantly elongated, because, and I'm insistent on this, which makes me sort of a pain, but it's constantly elongated because the antagonist muscle is chronically short.
Yes.
Right? So if your internal rotators in your hip, the pectineus, the brevis, the adductor, is really tight because of adhesions in the femoral plexus or because of degeneration in the hip joint, you're chronically internally rotated. That means your piriformis and your glute med are chronically elongated, which makes them weak.
Right.
Because they don't ever they're just elongated to elongated. They don't ever get to shorten and then elongate. You have to be able to do both to be strong.
Right.
So
and that's why we see these complexes all the time. So we talk about the psoas being chronically shortened and the glutes being chronically elongated, right? So we are sitting. So we are in perpetual hip flexion too much. We should not be sitting as much as we do. So our psoas, iliacus, our hip flexors get shortened. And then, like you just said, the antagonist is chronically elongated. There has to be a symbiotic relationship between agonists and antagonists, or flexors, extensors, internal, external, you name it. There's going to be an opposite muscle that we really have to pay a lot of attention to, especially when we work with FSM.
Yeah,
not a myopic treatment.
Yeah, it's just fascinating. I've had 2 impossible patients this week. One has a condition called SPG7, and I had to look it up again. It's a genetic abnormality where you're missing the enzyme that puts together the peptide that the ribosomes need to make a neurotransmitter. Somehow it involves the mitochondria. And there's this frequency for abnormal protein accumulation. And another place where, actually, this was the first place where I got in trouble with George, because he went through and came up with all these frequencies for the inner and the outer, and then this and then all these different parts of the mitochondria. It's whatever. How are you going to tell if they work? So I used the frequency for abnormal protein accumulation, which is what happens in SPG7. And it is incurable. And I've been treating her for 3 years and she hasn't progressed. And she should be in a wheelchair by now. And she's not. She's still progressing, but at about 3 or 4% of what she should be doing.
Wow.
And she's one of the recommendations, we finally put her in a brace. She was resisting that for 5 years. And look, if you fall and break something, it's game over. So get a brace and use a cane. And then I had to teach her to put her cane in her left hand because it's her right leg that's really worse. And then it's the part where you take one baclofen 3 times a day for the spasticity. You might consider taking 2 in the morning. We're not getting it with the spasticity. We soften it and it's better, but just try it. Okay.
Right.
And so it's a collaboration between FSM making it better than it should be. And initially, we treated her spinal cord, and that took care of the spasticity. Then after about a year, we had to start treating her brain. Yesterday, we were back to her spinal cord. And it's because the SPG7 has moved up to her arm and her shoulder. I thought, oh, it's just your neck and your arm. It's the SPG7. It's finally hit the upper extremity. It was just in the lower extremity for 3 years. And now it's okay. So I use Google a lot.
Yeah, nobody on earth would know all the things that walk into your clinic or have to think about treating them all the way an FSM practitioner might have to think about these things.
And then it's really fun when somebody walks in. My last patient last night just has a vestibular injury and low back pain. Arthritic knees. Yes.
And then you second guess it. Is it that easy? This is really all that's there?
He came in and one of his primary complaint, besides his knee pain and his low back pain, was, and he just mentioned in passing, his balance.
Hmm.
1 or 2 questions. I handed him the BIVSS. His score was 48 over 18. I said, yeah, don't even come back until after you've seen Rescue. Get your prescription. And that's when so now he came back and he said, can I get my lenses made at Costco? I said, absolutely not. Why not? So explaining that. But it's just a nice, simple shoulder would be nice. And then, so
I've had so many shoulders the last little while. You're right. I think you said it, they all jump on a bus and then I have to think, okay, what am I here to learn? I am here to learn something about all these shoulders.
pec minor.
Can you get out of my brain for a second? I was just going to say the amount of times that I just start now at pec minor and subclavian.
Subscap always.
Yeah, that's but now I feel like I have to treat subclavius and pec minor first
Back.
to get back so then I can go in.
Oh, okay. Hadn't thought about that. And then the labrum. That's been the last part, especially where they talk about how it happened. My dog pulled on the leash. Is there any way to jam the humeral head forward in the fossa without trashing the front part of the labrum? No.
Capsule, no. I think that's an important part to talk about is people will say, oh, I had imaging and my labrum's fine. I understand that you don't have a surgical repair labrum. However, there's micro trauma everywhere. And so people who have had dislocations, traction injuries, even though the labrum may appear fine and intact on imaging, still go to torn and broken in the labrum. 214 is labrum or meniscus. And I didn't like that frequency in the beginning. And now I am addicted to it. I can't never use it. It's like the holy grail of shoulder injuries.
Shoulders, hips, and
yes.
knees. And it's thank God elbows don't wait, do elbows? They don't.
No, they have that very pesky annular ligament that can get trashed.
Oh, yeah, annular ligament is really icky.
Yeah. It used to be icky. And now we have a frequency for it.
And for the 34 people who are with us on the 38 people who are with us in person on this adventure, all of you are now figuring out that you come to the podcast with or that, and maybe a glass of wine, but netter next to you. So it's, yeah.
So it's necessary. And it's not to say that you don't know your anatomy. And yes, there's all this great software that people have on their iPads and their phones and their computers. I'm sorry. Nothing to me beats netter. It's like my laminate. Like sometimes I'll go and look very quickly, but sometimes just having the page open for some inspiration can be very helpful.
Look at this. Would 214
help JAWS? Okay, so I have something to say about that. So I've fooled around with it a little bit because I've been doing a lot of work with TMJ, talk with Mariel and Chalmers all the time with our orthodontic patients. So I have used it because I've had an open mind about that disc, and it's on one of my TMJ talks. The disc that's in the jaw is not the same as the disc that's in our back. So those disc frequencies didn't work.
Well, 710 works. The annulus works, doesn't it?
A little bit, but for pain, so the superior slip of the lateral pterygoid is what attaches to the disc and pulls the disc forward, but the pain and the bleeding and the scarring is caused from the retrodiscal tissue, which is behind the disc.
Right.
So it's like this long band of scarves that are attached to scarves that are attached to scarves. You have to treat the pterygoid that attaches to the disc, attaches to the retrodiscal tissue. On a pathology level, we're seeing that the tearing, the bleeding, and the pain is more to do with the retrodiscal tissue because the disc in the jaw is this biconcave, mostly cartilaginous, aneural structure. So it's not innervated. So we don't get pain from the disc.
And the other thing with the pterygoid is that the pterygoid gets tight because it's protecting loose ligaments between the tooth and the jaw, And once the pterygoid gets tight, it gets micro tears in the flat connective tissue, because it's not a round ligament, it's a flat connective tissue that connects to that disc tissue. And so the pterygoid should relax when you close your jaw and let the disc slide back. The pterygoid doesn't relax because it's holding on for dear life because you've got a loose ligament where you had braces or you got hit in the mouth in a bar fight or you hit your face on the steering wheel. And so when the pterygoid doesn't relax, doesn't let the disc go back, the bone goes back, pulls the disc back, and it's that snap that causes the bleeding. Is that how it works?
So it can. So you're talking about reduction versus a non-reducing disc. So when a disc doesn't reduce in the fossa, and that snap. So when it's being dragged, that's when that retrodiscal tissue bleeds.
Okay, so it's on the forward pop, not the closing pop.
It's the drag.
It's when you open.
When it reduces and it snaps back, because the retrodiscal tissue is pretty much made out of adipose, it just reduces back and it just slurps it back into space. I'm sure the disc could get trashed in that fossa, so running torn and broken would help that, but the bleeding that happens, so running bleeding in the adipose has
open portion.
Correct, but like any type of TMJ work, so yeah, we're good at treating the pterygoids, but running bleeding in the adipose, so 18 on A, 97 on B, has been a total game changer because you don't think of
the adipose bleed.
The retrodiscal tissue bleeds because it's very vascularized. So when there's bleeding,
shouldn't it be 18 and 162 capillaries?
Yes, I've run that, but when you said it and I've never been able to unhear it, it's not necessarily a structure that bleeds, but if it was bled onto.
Okay, so then 3 and 97 as well.
Correct.
Okay, yes. Got it. Yeah, interesting. And 284 then, right? In 97.
Yeah.
Because there's like bruising back there.
Yes.
Fascinating. I will stop rolling my eyes on that slide in the core where you have all these tissues that you treat, mostly because I've got, what, a minute and a half to cover that slide. And it's just Ask him. It's
And I love being asked, but again, once you hear something and and it was during COVID that I took a TMJ course, and
yeah.
the videos that we saw of a cadaver, and they're on YouTube as well, of just the disc and how that retrodiscal tissue, which I didn't know much about, but to see how important that is, how innervated it is fascinating.
It has to be when you look at the innervation to the face, and
Yeah.
that is so you've got motor to the facial muscles. The pterygoid is innervated by the facial nerve. Trigeminal is sensory. Every
Yeah.
other motor in the face, the pterygoid has got to be facial nerve. It's masseter, pterygoid, temporalis,
I'm going,
whatever this little thing is. Thank
and
God for Google.
honestly, pterygoids, both lateral and medial, are innervated by mandibular branch of trigeminal nerve, cranial nerve 5.
What? Trigeminal nerve is motor? Wait, facial nerve is motor. Trigeminal is not just sensory. Trigeminal is motor. That makes my brain hurt. Just when you thought you knew something, you don't. I hate that part.
Speaking of, we have some questions to get to.
That's a lot easier than dealing with weight.
As I continue to
The
Google,
pterygoid is innervated by the
I'm going to have to
trigeminal,
keep looking at this
the
because
mandibular branch of the trigeminal, the maxillary branch of the trigeminal nerve.
lateral pterygoid innervated by mandibular nerve, which is third branch of trigeminal nerve, cranial nerve 5.
So
Specifically, the patient comes from
the
the anterior division.
mandibular branch goes up and innervates the pterygoid, which is actually in the region of the maxillary branch. This middle part is the maxillary branch, right?
Yep.
So the trigeminal nerve is both motor and sensory? Okay. I'll be fine. I'll
Branch
just,
of mandibular nerve. Wow.
okay.
I want to get Mary on the phone.
Marion,
Oh,
he's gonna be in Phoenix. Do you guys realize, what is happening in Phoenix? There's
magic.
just Resky, Mary Ellen, Jay Shaw, Eduardo, the Juliana Mortensen, Jennifer Ernst. Now this, we had to shorten it because Diana Cross announced 3 weeks ago, 4 weeks ago, that she's coming up. I'm coming. I have an hour. And it's, wait, it's all full. Okay, I had this hour presentation, and now we're going to squash into 30 minutes. So it's Diana Cross is coming with more news on whatever 124 is supposed to be doing.
Can't wait.
And then Jennifer Ernst, we have the data from the Feinstein Institute. You guys, the vagal tone protocol is patented. It has enough data that Tivik has a patent on it. I just want you all to swim that there for a second and understand why, if the only reason you came was for that little 30-minute thing that we get, because I got 20 minutes on what the Vegas does, and she's got 10 minutes on the data, which is, and then we all have an hour with Dinah Cross. Okay, questions. Mom had a stent placed a year and a half ago. Stents are nice. Mild electrical heart block. That's like being a little pregnant, but that's another. And congestive heart failure. Those two things go together. I have run off a seminar. Wait, congestive heart failure. Time out. How long has she been on statins? I have run off a seminar. Great results for a number of things. Never run heart health. Oh, no, it's not beyond your area of expertise. Heart disease, all heart disease, is inflammation, oxidative stress, and autoimmune dysfunction. That's problems with the heart. Congestive heart failure. So there's a little bit missing here in the history, which is heart block is when the electrical system on the left side depends. You can have left bundle branch block, right bundle branch block. You can have both, one or the other, or both. Usually it's left bundle branch block starts first, and then you get right bundle branch block. There's this electrical wiring that goes up the left side of your heart that makes it go smush and contract. And the insulation gets thin, and heart block is just the wires don't work. It's like your heart's been inflamed long enough that it's dissolved the myelin that's on these. I think they're myelinated nerves because they're really fast with your heart. And so heart block, I get that just happens when you get old. Congestive heart failure does not necessarily go with heart block, right? Congestive heart failure goes with statins. I'm gonna guess, I can't guess. I have to ask, how long has she been on statins? Because one of the main side effects of statins is congestive heart failure. It kills the mitochondria in the brain, the heart, and the skeletal muscle. I have run FSM on her. Heart health can't hurt anybody. It's everybody. Everybody should run heart health on themselves once a month. Men and women, but especially women, should run breast health on themselves once a month. So you can have my once a month program that combines heart health and breast health. And you just have reduced inflammation in different tissues for the two sets. And you put a magnetic converter on one side of your chest and a magnetic converter on the other side of your chest, pick up the breast and the heart, all in between. Reducing inflammation in the heart is not beyond the area of your expertise. It's a no-brainer. There's nobody it's going to hurt as long as they don't have an infection or infectious pericarditis. And she doesn't have that. She lives in a traditional as well as an alternative medical desert. Condolences. No one else for her to see. I'm with her right now. She's not experiencing any symptoms. Yay. Was wondering if there are contraindications or any wish. No, there's no reason not to run heart health on her. It would be okay. Recommendation, either one. Wet towels, pulse DMF, depending on how old your mom is. Wet towels are just a pain. Use wet washcloths on either side of her chest. I prefer not to run them back to front through the heart. Either side is just fine. So you create a field that goes through the heart. Warm, wet washcloths, and then cover up with something that keeps warm. If you have a magnetic converter, use that because the heart likes pulse DMF and it works just as well. If she is not on 400, yes, I said 400 milligrams of CoQ10, if she's on statins and her cholesterol was 350 or 400, statins are fine. I'm not going to fight with anybody about it, but she has to be on 400 milligrams of CoQ10 if she's still on statins. And D-ribose is what Mark Houston uses for congestive heart failure. The other thing with congestive heart failure is the heart doesn't use, like your skeletal muscles use sugar to make the mitochondria work. The heart doesn't use sugar. There's not enough energy in it. It uses fatty acids. There's this fat pad on your heart, like right in the middle of it. And the body just replaces that and your heart uses it. All right. As you get insulin resistant, everybody that's over the age of 30, look down at your tummy. And if your tummy is sticking out just a little bit, that's insulin resistance. Embryologically, the fat that's in your heart fat pad is the same embryologic origin as the fat that's in your tummy. That gets more insulin resistant as we get older. So type 2 diabetes is insulin resistance to start with. So you want to run insulin resistance, or at least inflammation in the adipose is part of heart health. And that's why it's part of heart health, because you want the fatty acids in that fat tissue to be more available for the heart to use for energy. Congestive heart failure is the muscle can't get enough energy to contract properly, so it gets weak and it gets big. It tries, but that's why it gets big. Sorry, that's
No,
a hot button for me.
perfect. But she just said, the person that wrote that said that she got her on CoQ10 sometime after her stent. So that's great.
Okay. All right. So make sure. So look at her cholesterol. That's the other thing. If her cholesterol is 200 when they put her on statins, that's dumb. 200 is normal. If her cholesterol is 400, then you can make a case for it. But it's a whole different conversation. Sylvie, patient who had a resection. Ugh. Oh, this is okay. Resection of an acoustic neuroma, loss of hearing and dizziness, no fooling. What is the frequency of the eighth cranial nerve? I'll let you, I don't have it in my phone yet. JJ is going to show me how to put it on my buddy. Oh, wait, I have a thing. JJ sent me a text with that. There it is. Here it is. Eighth nerve, vestibular coccygeal nerve, 114, which is also the frequency for the thymus, which is why I had this difficulty with Jorda's T, right? It worked anyway. And 137 is the vestibular coccygeal nerve. Yeah. And acoustic neuromas are, an acoustic neuroma is a benign tumor that gets onto the eighth nerve inside the ear, or maybe a little behind the ear, but you have the facial nerve and the eighth nerve does the vestibular system. You have the vestibular edge of it and the hearing end of it that goes to the cochlea. That's the eighth nerve. But the seventh nerve that does sensation to the face, right? Isn't that seventh? Oh, no, go away. Oh, Piper, I'll tell you later. Yeah, acoustic neuromas, when they go in and take the neuroma out, they damage the nerve. And it's, if she has loss of hearing, she's dizzy because there's no nerve going to the vestibular system. Sylvie, I don't think you can treat it. They take the tumor out, but they cut the nerve. And this is normal. The dizziness usually goes away. The hearing never comes back. They're always deaf in that ear. And if you're lucky, you can try 40 and 44. You can try, if there's no nerve, I don't know how you can increase secretions in our nerve that's not there. And then the part of the brain that does vestibular, somebody tell me, I think it's the temporal lobe, right? It's like just inboard from your ears, and that's the only thing there is the temporal lobe. So it should be the temporal lobe. So we have a frequency for that. You can try that. That's a tough one. You got the frequency, see if it works. Okay, there's Leaf. You covered George's cranial nerve. Any update on the motor center numbers and exactly which centers they represent? Absolutely, totally, 100% no. I've never used the motor centers. I use 92. I don't even know what the motor centers are or where they are or why they're even there on the list. We have motor centers, we have sensory centers. Are they in the brain? Are they up here in the sensory motor cortex? Are they sections of the sensory motor cortex as you step down the homunculus? Don't know. Sorry, Leaf. I'll see you in a couple of weeks. No. Okay. Is there anybody have a question I can answer?
Those were good to be finished, all the ones that.
Oh, good. Yay. Yeah. And the chat, we're not too chatty today, so that's good. Kevin did the chat part.
Well, okay, we went nowhere near my list today, but that is fine.
You got 10 minutes to start on your list. I love your list. It keeps us grounded.
The list was piggybacking off of, after we got off last week, we did a lot of spine, disc. One thing that the pathology that always seems to come up every so often, whether it's on the podcast or at the course or I get an email, is stenosis. And it's that face. And a lot of people have stenosis. And for some reason, people seem to think that FSM is contraindicated or it's going to make it worse. It's not. So let's just say that. And FSM can still be helpful even when there is stenosis present. I think the only time we had the cautionary tale was with 40.
With anything you want to do with the spinal cord, so this lady with this disc bulge that goes into the middle of her cord, that is stenosis. Everything that I run from her neck to her feet has to be alternating. I can't polarize anything. As far as I can tell, when you polarize the current, it appears to, just clinically, it's like it increases the spinal fluid flows up the dura, around the brain, down the center, then back up the front, and then around, and whatever the flow is. Okay, so when you polarize the current positive, the first thing that happens is the pain. If the patient has stenosis, they will say, oh, it hurts in between my shoulder blades. And then the next thing they say is, whoa, I got a headache. All right, now if you look at what does that mean, if you take that apart, if the spinal fluid is trying to come down and the stenosis blocks it, right? What is it? What is the spinal fluid pressing on? It's the disc annulus. So there's pressure on the annulus. They get pain in between their shoulder blades first. And then as the pressure builds up, so you got a hair in the drain here, can't get down, pushes on the annulus, you get pain on the shoulder blades. And then it fills up and fills in the ventricles and increases intracranial pressure, and they get a headache. Stop the current, make it alternating. That's the first thing you can do if you catch it soon enough. And you can tell I'm speaking from experience. So you make it alternating first. If that doesn't work and they still have a headache, you just have them sit up. I had one that just was really bad. She had stenosis I didn't suspect. And so she sat up, and I ran just inflammation in the spinal fluid and got her headache down. Now, if you know from imaging that they have stenosis, you treat the spinal cord. So you already know that the spinal cord is at least touched by the disc annulus, and the disc annulus may be leaking. So you have to run 40 and 10 to get their body pain down. And if there's enough compression, you might have to run 81 and 10 to get the tone down in their legs and their trunk. And you have to do those alternating neck to feet. But then sometimes stenosis comes from facets in the back, arthritis pushing on the backside of the cord, and the disc, which is calcified and fibrosed and nasty, it's pushing on the front. So what would you do? You'd run where is the pushing on the back coming from? 217 hard calcium, or 91 in the periosteum and the joint capsule on the backside, and on the disc annulus on the front. So you set up from front to back at the level of stenosis, front to back at the neck, to treat the disc annulus and the facets in the back. If the stenosis is in the lumbar spine, it's not a deal. The lumbar spine stenosis is almost always at L3, 4. And as long as they can feel their crotch, urinate, defecate, as long as they can do those things, the stenosis in their lumbar spine is just about nerve pain. So you treat nerve pain, and there's no spinal fluid problems there at all because there's no spinal cord at L3. Spinal cord stops at T10. It's not there. So
Right.
L3 stenosis is easy. You just keep the nerves and make sure they can feel the crotch. If their crotch gets numb, you call the surgeon. That's
Yes.
I'm a little hyper today, huh?
No, it's good. It's good. It's good energy. Like everybody else, I'm just like taking it all in because you always hear something different. But yeah, I just wanted to, like I said, stenosis is always something that comes up, and it's not contraindicated, but there are just things to be aware of. And the way you explained it, it makes just total sense of why we are aware of it. It's like an acute injury when there's a lot of inflammation. We don't want to ram a sharp positive current through an already hotbed of activity. I just think about that. Stenosis, just like an acute inflammatory response, there's so much activity, throwing a lot of anything more at it is just chaotic.
You just have to think of cervical stenosis like hair on the drain. It interferes with spinal fluid flow and it backs it up. I have to figure out a way to talk about it so that it doesn't scare people. Apparently, I have too many slides about it in the core because you don't see it very often in the first place.
No, I see a fair bit.
Do you?
The last couple of years, I definitely have.
Remember, you asked for more difficult patients.
I did. I remember that plane ride.
I remember warning you about that.
It was answered, and I'm grateful because I'm learning so much, and maybe that's why I'm seeing that and learning all about shoulders all over again. I don't know.
And at 4 o'clock in 2.5 minutes,
Yes.
I get to do the intro to FSM webinar.
Yes.
And we've got like 300 and some odd, 400 people signed up for it officially, but anybody can join in. And it made me go over the introduction. Why would you do FSM? And there's this one slide that I just had so much fun with. It was really cool.
414.
414. 414 people? Really? That's
Not
gonna be so much.
everybody will be on. but
Yeah.
That's an average.
And it'll end up on YouTube. But the intro is really fun, and I think we're going to put it on the resources page for practitioners so you can send it to people. How does FSM work? Why would I use it? And I only used, with 2 exceptions, I only used published papers. Everything we have is data. Oh, can you give the link? And there's Kevin.
I was just going to interrupt to say, Kevin, can you? But you
Yes,
already
the other one until we get off this one.
Yeah, I
know.
Are Ehlers-Danlos patients more susceptible to stenosis? In some ways, yes, because their connective tissue is looser and they're more likely to get dysbulges.
Right.
So it's possible, right? And then there's the whole tethered cord thing that happens with Ehlers-Danlos patients. There's a higher propensity for tethered cord. Go looking for tethered on an MRI. The tethered cord, it so far has been really easy to treat. It's the spinal cord should end at about T10. When you have quote unquote tethered cord, it's down at about L1. It just stretches the cord a bit. And so you treat the discs and you treat the cord for 40. So
And it's 4 o'clock, and I'll let you get off here and get on the new one. And I'm so glad you're doing it. And thanks, everybody.
thank you.
Some of you guys will probably need to log off of this one and get on the other one if you're staying the extra hour. And we'll see everybody next week.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.